Well, thanks for having me, guys. Yeah, so I mean, I presume most of you guys or many of you guys are either patients or caregivers. And while I'm neither a patient nor a caregiver at this moment, we all have something in common. So we've probably all sat, three of us, patient, caregiver, and doctor, in a meeting room for the first time, trying to work out, the long and complex conversation about the new diagnosis, the symptoms, the treatment options, the side effects, the prognosis, all this stuff. So we have different perspectives, most likely, in terms of that meeting, in terms of what we hope for or are afraid of, or the questions we have, or the ways we process that kind of before and after. But I was thinking about what to talk about today, and I was kind of getting myself caught up in lots of little details about different treatments and outcomes and side effects, and I couldn't quite narrow down what to talk about. There's so much new stuff in lung cancer. So this idea just kind of came to me, so I ran with it. So I'll be curious to know if this is a topic that you guys find interesting or useful. So feel free to let me know later, and interrupt me with any questions while I talk, or afterwards. I'll be open for Q&A for a while as well. So let's make this a two-way conversation if y'all would like to. And there's no disclosures. I mentioned a couple of drugs by name, but it's not on purpose. So no financial disclosures. So let me just see how this works. All right. Happy birthday to the LiveLung support group. As Lynn said, 3 years, I think. Is that right? 3 years old this month. And happy Lung Cancer Awareness Month, everybody. So let's keep up the awareness. So my topic today is how I approach a new patient with stage 4 non-small cell lung cancer, or pulling back the curtain and peeking into the mind of an oncologist. So here we go. For background, I'll give you guys a couple questions. So what do you think the most common type of lung cancer is? I guess unmute.
It's yeah, we're muted, but I'm just unmuting myself. But yep, non-small cell.
That is right, non-small cell lung cancer. And we stage this, as most of you probably know, 1 through 4. Technically, we have 1A, 1B, 2A, 2B, 3A, 3B, and 4. And what do you think the most common stage is when we finally discover this diagnosis? Anybody want to guess that?
3.
I think I could be wrong. I think it's still stage 4. Which is discouraging, right? But we have so many new and improving treatments for stage 4 non-small cell lung cancer. So that is why I wanted to talk about this today. It's very common. So let's look at the process that I go through with each new patient and see if that helps anybody. So before I can discuss any of this stuff, the diagnosis, the stage, the treatment, I have to review or gather information. A lot of this is done before I ever walk into the room. So if you're waiting in the room for your doctor for a long, long period of time, it's not because they're out playing golf. Maybe they're out looking at your chart, trying to figure out what they're going to tell you. So cut us a little bit of slack sometimes. But it does take a while to kind of gather all the information. So the first thing that I look at is so there's chart review, and then there's direct patient encounter. And the first thing we look at is the history. So obviously we can gain some history from the chart, and a lot of that is the old-fashioned tell me how you're doing history in person. So the things that I care most about, because we could talk all day, but the things that the focus history is, things most important to me are what were the symptoms that led to the diagnosis? What are the current symptoms? And that would then lead to the question, do we need to do anything differently to treat these symptoms better? Are there any kind of symptoms that are not being well managed? Is there cough, trouble breathing, pain, fatigue, weight loss, anxiety, a variety of things many lung cancer patients have when they walk in the door, and many of them are not well controlled at that point. So after reviewing the chart and talking to the patient, of course, the physical exam comes fairly soon thereafter. While there are lots of elements of the physical exam, the ones that seem most important the oxygen saturation. It gives us a pretty good clue as to how the patient's oxygenating. The weight, specifically if there's been weight loss, can help us understand a little bit better about how sick the patient is or how long they've been sick for. The heart exam, lung exam, I think fairly obvious, listening for different things that would indicate maybe some fluid or some blockage or just the degree of tumor. The neurological exam can be helpful because, sometimes these can be spread to the brain and sometimes it's not very apparent. So looking for anything neurologically that may be new or different. What else did I put on my list of things to say here? Oh, performance status. So the performance status is just a term we use to kind of indicate how strong the patient is and how well they may tolerate treatment. So it's asking questions about, how much are you up out of the bed and active and engaged throughout the day doing chores and doing things, or how much are you bedbound and bedridden, to kind of get a sense for, how well they may tolerate the treatments. And I'm also looking for any signs or symptoms that may need, again, further palliation with, say, a pain medicine or a cough medicine, but also, there are things sometimes needing like radiation therapy for pain as well. So just trying to look for symptoms or signs that might indicate a symptom to manage, or even though we don't think it's stage 4 at that point, maybe there's something that on the exam or in the history that makes me think maybe there's some place we should go look for. So history and physical also help us hone in on the stage a little bit too. So laboratory data, anemia sometimes we see in cancer patients. Sometimes the white count can be high from steroid use, which is used for different lung symptoms. Importantly, we'll look at the kidney and liver function, because if we need to do drug therapy, which is usually how we treat stage 4 cancer of the lung, which we'll get to that in a minute, knowing that the liver and kidney are healthy helps us to know that they can tolerate the treatments. And if not, we may have to make some adjustments. And then imaging is a very big part of this, of course. Usually chest x-rays are done and CT scans of the chest, and then trying to move this thing around. Sometimes PET scan, bone scan, brain scan. So a lot of these things are already done when I meet the patient. Sometimes they're not all finished. And these are important to help figure out what stage. So we have a clinical stage and a pathological stage. The clinical stage, as it sounds, is using clinical data. So the size of the tumor, the location of the tumor or tumors. So the CAT scan and PET scan really give us most of that information. Also trying to figure out the bulk of the cancer, or the size, or not so much the size, but kind of the degree of involvement, because the larger and more kind of symptomatic a tumor may be, it may indicate a more urgent need for treatment. And the less symptomatic or less bulky or less large may give us a little more breathing room to kind of wait till we have more information to make a treatment decision. I mentioned the radiation earlier too. Sometimes we'll find areas that might need radiation even without any symptoms. So a common area would be if there's a metastatic spread to the hip bone, the femur, or somewhere near the hip there, that would be at risk for potential fracture. Even with no pain or no trouble with the walking, we might want to radiate that area to prevent a fracture. That would be a bad complication to have. Same with the brain. If we find brain metastases that are not symptomatic, we oftentimes still will radiate those to prevent problems. So imaging is obviously very important. The next one is pathology, and that's becoming increasingly important in 2020. And I'll talk a little more about that in a minute. So let's look at this. So, a long time ago, we would just sometimes get a pathology report that said malignant cells, and we would just accept that for lung cancer and move on. But now we need to know a lot more than that. So hopefully the pathologist can tell us, is it carcinoma or is it something that's not carcinoma? So there are a few other lung cancer types that are non-carcinomas, such as mesothelioma or carcinoid tumors. But most of our lung cancers are carcinomas. And then the next kind of more specific line of questioning would be, is it a small cell or a non-small cell carcinoma? and that usually can be determined with the pathology. So again, most common is non-small cell. And then within non-small cell, as you may know, there are different types of non-small cell. There's squamous and non-squamous. Non-squamous is the more common type in 2020 and has been for a long time. And then within non-squamous, there are actually several types. The most common is adenocarcinoma. There are other types as well. So, knowing exactly what subtype of lung cancer is very important because the behavior is different, therefore the prognosis is different, and the treatments that we use are now different. They didn't always used to be different, but now they're different. So I want to go back and look a little bit in the past to kind of see how important, why pathology is so important now. So in 2003, basically we had two options for our lung cancer patients, chemo or no chemo. And it was really a two-part question. One, does the patient want to take chemotherapy or not? And assuming they did, then the doctor had to decide, are they fit enough or healthy enough to tolerate chemotherapy or not? And there were a few different drugs to choose from, but there really was not a whole lot of excitement between the different types. So it was really a different era back then. And then in 2004 is when we first started having targeted treatment. And the first one was for EGFR mutated lung cancers, and that's been a huge thing. But still, that's a small percentage of patients. EGFR remains our most common treatable or actionable mutation. I think we saw, I haven't seen this written down, but I think we saw a lot less EGFR lung cancer patients 15, 16 years ago for a couple of reasons. I think that we are now testing for it way more often. I started my practice in 2004, so I can remember those days well. It was kind of a situation where a lot of patients did not get that test run, and some did, and it was kind of a little bit of a fight to get all those tests done. So a lot of patients back then either weren't tested for it or it was tested, but I have to believe the testing is better now. And then back then it was, we also got biopsies that were maybe less robust. So the pathology material was maybe less robust, wasn't tested for as often, maybe the tests weren't as good. And then now we also have liquid biopsies or blood-based biopsies as well as tissue biopsies. So for a lot of reasons, we're doing more testing now. And then the other piece to that is that EGFR mutated lung cancer is commonly seen in younger patients and non-smokers. And we have a lot more lung cancer patients now, as a lot of you guys probably realize, that are never smokers and that are younger. So we're seeing more EGFR mutated lung cancer now than we did 15 years ago. 2016, this drug called bevacizumab was approved for lung cancer, had been previously used in GI cancers. And around that era, we were using this drug everywhere we could. We were trying to get in ovarian cancer and breast cancer and lung cancer and GI cancers. And it did get several approvals, and that was kind of the thing to do back then, was try this non-chemotherapy biological drug. It works through the blood vessel systems around the tumors, and really the data, just in a nutshell, was it improved the outcomes, but it was not a dramatic improvement, and the benefits were certainly outweighed by some of the potential side effects. Don't want to get too much into details today, but it changed the landscape of lung cancer, but not dramatically. So still, things were pretty similar. 2008, we finally learned that adenocarcinoma and squamous cell carcinoma, we knew they behaved differently, had different prognosis, but we didn't treat them differently until around then. And then we learned that two different drugs worked better for their specific subtype. So we began using pemetrexed more for adenocarcinomas and gemcitabine for squamous cell carcinomas. Again, not a dramatic difference, but enough to get some people pretty excited. But really, it wasn't until more recently that we really changed things. 2011, the ALK positive drugs were available for lung cancer, or for ALK positive lung cancer. Again, that's a small subset, less than 5% of patients. The patients that have ALK and EGFR generally do really well. And we have great treatments for them now, more and more and more, like, more than a handful of different options now. So it's really amazing how fast we keep learning about new ways to treat these two subtypes. But again, most patients don't have these mutations. So in 2014, for most of my patients, it was the same thing as 2003, really. We had chemo. Yeah, we had the two different chemo types, one for adeno and one for squamous. And a few people got bevacizumab and a few people got the targeted therapy, but most still got chemotherapy. It wasn't until immunotherapy was approved in 2015 that things really took off. And you guys have seen the TV ads, if nothing else. There's a lot of immunotherapy interest. And now, 5 years later, we do a much more tailored approach to treatment based on individual pathology. So let's see, 1, 2, 3, 4, 5, 6, 7, 8 different mutations that we have treatments for now. And that list is growing. There are several others that are in trials right now as well. So that's why pathology is so important now. Back in 2003 and even 2014, it didn't really change patients' treatments very often. But now the treatment really hinges on the pathology because it's such a vast difference in terms of outcomes and treatment options, depending on if any of these things are available or abnormal. So pathology is more important than ever. We have to review all the path reports very carefully. That's my job to do before I meet the patient, make sure I don't miss anything. And if I have questions, then have to go back and ask. Sometimes the pathology will change the stage. We may think it's a certain stage on the CAT scan, but the pathology may show something that we didn't know was there. So that can upstage the patient sometimes. Have to make sure the subtype is clear, like we talked about. And then is there enough tissue for molecular testing? So we are, the pulmonologists, the lung doctors, and the radiologists that do the image guided biopsies. They're all very well aware of the importance of tissue now, and we're getting better biopsy samples. So we're doing a lot better now than we used to do a few years ago. But every now and again, there's still not enough tissue for molecular testing. Sometimes that's because the specimen itself is small. Sometimes it's because there's a lot of necrosis or dead cells inside the specimen. And that's just a function of the biology of that tumor. So if there's not enough tissue, then we have two options. We can rebiopsy the patient again, which is not always met with excitement, but sometimes needs to be done. We can also obtain blood for the liquid biopsy for molecular testing. And we can talk about that in a few minutes further. So I'm gonna maybe just pause. Anybody have any questions about any of that stuff? I said a lot in a few slides.
You sure did say a lot, but I just wondered if you would mind explaining is there much difference in treatment or prognosis or anything with the carcinoma and the carcinoid?
Yes, it's almost two different cancers. So carcinoid tumors are a neuroendocrine tumor, and there is a spectrum from low grade to high grade. And the traditional carcinoid tumor is a low grade tumor. Sometimes these can be watched for years without even any treatment. It really depends on what stage they're at. If a low grade carcinoid is found at a stage 1 or a 2 and is removed, or even a 3, and there's no residual cancer, we just simply leave the patient on. There's no adjuvant therapy for that. If it's stage 4, carcinoids are actually more common in the intestines. They can be found different places: the small intestine, large intestine, prostate, different areas. But if it's any carcinoid from any place at stage 4, if it's not symptomatic and it's having a slow rate of growth, we can again watch that patient for months or even years without treatment. There's a shot called sandostatin or octreotide that can be used once a month to help the carcinoid tumors. Generally, it's more felt to be tumorostatic, not tumoricidal, so it doesn't kill the cancer as much as it just stabilizes it. So it just kind of keeps the lid on the pot. And I've had patients with carcinoid tumors that are the kind of low-grade carcinoids with stage 4 disease live, 10, 15 years, and the disease just sits there, and we give them the shot every month. So it's a very different disease. The The intermediate grade carcinoids or the atypical carcinoids are probably the least common. It's a little bit of a mix between low grade and high grade, so it's hard to kind of know how aggressive those are going to be. We sometimes will use the same treatment. Sometimes we will treat them more like high grades. It depends more on kind of how that individual patient does. The higher grade carcinoids we treat more aggressively, like a small cell lung cancer. Small cell lung cancer is also a neuroendocrine cancer, but there's a difference between a small cell lung cancer and a high grade neuroendocrine carcinoid that's not a small cell. So it's a little confusing from a pathology perspective, but those patients usually get chemotherapy.
Thank you, Dr. Newman.
Question a little bit?
Yes, thank you.
Sure. Let's see, what's my next slide going to tell us? All right, so, when I walk into the room, I feel like I've got about 3 jobs to do in terms of that new relationship. And one, I've got to understand the situation and the options. So that's what I've been doing in terms of reviewing the chart and getting the pathology and the imaging and everything else kind of all in one place in my mind to kind of know diagnosis and stage and prognosis and treatment options as best I can. Some of that stuff has to continue to wait until more results are back, but I have to understand what's going on. Number 2, I have to communicate that to the patient and oftentimes to a caregiver or more. And so that's another kind of separate, somewhat distinct job, I think. And then 3, I've got to also try to have a 2-way conversation and understand the patient's goals of care and help them make some of these decisions. Ultimately, it's the patient's decision, and I feel like I'm the one that's giving the advice or the information. But I think it works best when we all work together. So what else do I need to do? I've talked mostly about number 1 so far, how to get all the data. Again, I may need some time to gather additional information, like maybe the patient has not had a PET scan yet. We order a PET scan and get back in touch a few days later, or a brain MRI has not been done yet. We'll get that and get back in touch. Most commonly, it's the pathology that's still pending with the molecular testing. But in terms of the communication, these are some sample questions that I may ask the patient. I may say, explain to me in your own words what you understand about your diagnosis, the situation, the options, and why they sent you here. This helps me know where to start the conversation and where there any gaps may be, and also engages the patient somewhat. I don't feel like it's my job. I don't feel like it's good care for me to walk in the room and say, hey, I'm the doctor, you've got this cancer, this stage, this is the treatment, we're going to give it to you next week, and walk out of the room. I mean, I hear that when that's done, it's not well received, and that's not how I was taught to behave. So I'd like to kind of sit with the people and understand what they know and what they don't know, and then try to fill that in. And also, what things are most important to you. For example, how much do you value the quality of life? How much do you value the length of your life? And you can value both tremendously, or you can value one more than the other. Everyone's got a different view on that. How much are you willing to put up with in terms of inconvenience, side effects, suffering? Again, everyone answers these questions very, very differently. And ultimately, how do you feel about the benefit of the treatment we've been discussing? Does it seem worth it to you based on the side effects and then the prognosis? So I think that everyone has a different, a view on these things. And I don't want to assume that just because there's a young, healthy looking person in the room, they're going to want me to go full court press on every possible treatment, despite the side effects. And also I want to presume if there's an older person in the room, they don't want anything done. I mean, it has nothing to do with age, has a lot to do with, the person's personal feelings on things and their situations. So I think that's I can't know the answers to these questions without asking the patient. So at the end of the first visit, again, when it's kind of winding up, I may need more time for imaging and pathology. The molecular studies. Okay, so I was going to kind of poll the group here, quiz the group. What do you think I would say would be the average turnaround time to get the molecular test back from the tissue biopsy? So I'll say a lung biopsy or a bronchoscopy, and we're waiting on the pathology to get that molecular test. Anybody have a guess about that?
Couple of months.
I was gonna say 2 weeks.
Yeah, so,
I'd say a week.
okay. So we wish it was a week. It seems to be about 3 or 4 weeks. So that's a challenge sometimes when people hopefully get referred quickly and get in quickly, and then we're sitting here waiting for this for 3 more weeks. It's getting better. Maybe it's closer to 3 weeks than 4, but it's still a long time. How about the molecular studies from the blood? Anybody want to guess about that?
I think mine was 3 weeks.
Well, they're actually saying 7 to 10 days on the blood. We've been getting them sometimes in 4 or 5 days even. So there is a difference in terms of the speed that we get these back. Let me back up. So I guess I could get into more about this. So there's pros and cons to doing both of these tests. And some patients end up having both run, some just one. It just depends. So the molecular testing on the tissue tests for about 140 genes, and the one from the blood tests for about 70 genes. Although those 70 are, those all include the ones that we know how to treat. But what they also include is ones we don't know how to treat. So it's very common to have a result come back from either test that shows a mutation or an abnormality that we don't know what to do with. But that's still important because maybe next month or next year, there will be a trial that's shown that there's a drug for that exact mutation. So you never know. And then some of those mutations or abnormalities are actually, there are clinical trials ongoing looking at those same questions at new drugs. So all the companies that run these tests do a good job of letting us know about the clinical trials that are associated with each of the mutations, so we can talk to patients about that. Unfortunately, a lot of these trials are out of state, just the way it works, but it's nice to know what's coming. They're both really good tests, so I don't want to say one's better than the other. It's nice to have 2 options, and we have to kind of figure out clinically what makes the most sense with which one to do and when to do it. So here's another question. Can you think of a scenario that I might want to start somebody on treatment without waiting for the 3 to 4 weeks or even the 7 to 10 days and need to treat them sooner?
If they're symptomatic.
Yeah, I mean, that's the main one. Urgent tumor response needed due to severe symptoms, right? So if there's uncontrolled pain, maybe you could argue we could manage that with pain medicines, but if there's trouble breathing that's really tenuous and the airway's blocked and there's a big tumor there and we really need to get treatment sooner, although again, we might use radiation in that setting, but there are certainly circumstances, maybe the liver's full of tumor and the liver's kind of teetering on failing. There's situations where we need to get treatment right away and we just can't wait a week or 2 or 3 or 4. So whenever we do have to treat somebody urgently, we typically use chemotherapy alone, usually just 1 cycle because we have all the answers before cycle 2's due. Even if we have a situation where they have a tumor profile that suggests a very high response rate to immune therapy. So why would I give, so let me pause for a second. So the immunotherapy, we look at this thing called PD-L1. You guys have probably all heard about this. And the PD-L1 is a score they give from the tumor that rates it anywhere from less than 1 up to 100%. And less than 1 is considered negative. 50% or higher is considered high positive, and anything in between, which is 1 to 49, is considered positive, but not high positive. So we know that when you have a 50% or higher PD-L1, you have a higher response rate to immunotherapy. So there's always excitement about, oh, wow, my PD-L1 is 60 or 70 or 80%. I can do immune therapy. I can skip chemotherapy. Those are some of the things that we're thinking or talking about. You may not choose to go that route, but even in somebody who's 100% positive PD-L1, if we don't have all of the data back in terms of EGFR and ALK and those other molecular tests, we don't give them immunotherapy, we give them chemotherapy. Anybody have any idea why that is? So
Would it
Because
be,
with chemo, it's a known quantity as to what you're going to get or should get versus immunotherapy. And if you haven't got the labs back, let's go with something that's tried and true versus something that is not.
Yep. John, you gonna say something too?
well, I was just gonna say that maybe the response to chemotherapy would be quicker than the, immunotherapy.
So good answers. Sometimes we think chemo response rates are quicker. I don't know if that's true or not. If someone's got a PD-L1 of 100%, they do really well with immune therapy. And it is true, Greg, that the chemo is kind of tried and true in terms of what you get, and the immune therapy sometimes can have some wild side effects. But the real, oops, I didn't give the answer. I'll tell you the answer. The real answer is that some of the treatments we use can impact future treatment. So the sequence that we use them is important. And this has most clearly been shown with when immunotherapy is given first, and then somebody turns out to test positive for EGFR, which is a great piece of news. And then we go and give them the EGFR directed therapy, the pill for that. For whatever reason, having that immune system revved up, even just for a few days or a few weeks, increases the risk significantly of side effects from that EGFR pill. And the main one is pneumonitis, lung inflammation, which you can imagine is one of the toughest problems we face with immune therapy. But a lot of lung cancer patients have symptoms in the lungs to begin with, and then you add inflamed lungs from the treatment. And there have been some deaths reported in the trials where patients were given immune therapy prior to the targeted therapy for EGFR. So it's been very clear, and this was not known until we started doing this a couple of years ago. So now it's pretty well known not to do that. So we give one dose of chemotherapy, let the dust settle. If there's no EGFR mutation or other mutation, then we add immune therapy with dose number 2 and keep going. But if they happen to have the EGFR positivity, then we take the chemotherapy off and give them a pill instead, most likely at that point. Does that make sense? So it's a little complicated. All right, so the patient's like, doc, just give me some treatment. We've been talking for an hour and you still don't know what I need, and you got to wait 2 more weeks for this and 2 more weeks for that. So once we finally get everything in, we review it all again, the diagnosis and the stage. We should be able to answer those questions a little bit more definitively then, as well as the prognosis, as well as the treatment options. Of course, every option has benefits and side effects. And as I kind of alluded to with the questions about, quality of life type questions, no 2 patients really view the benefits and risks the same either. You can tell somebody that, hey, this drug's going to increase let's say your odds of being alive at 5 years by 5%. And one person may say, that's fantastic, sign me up. Another one may say, man, that's nothing. 5% is not enough for me to take this drug. So you just never know until you kind of ask the patient how they feel. So again, I have to take all this into account, patient's goals of care, as well as all the data, and finally arrive at a plan. So I think just to kind of further illustrate this, I photographed a couple of slides. So there's this group called the National Comprehensive Cancer Network. It used to be 13 cancer centers, it may be more now, but they've picked themselves around the country, and they do a lot of things for us, including give us guidelines. They update them on a regular basis in terms of all kinds of things, diagnosis, treatment, surveillance, et cetera. So it's like a 200-page document for lung cancer, or for non-small cell lung cancer, actually. So this is one of the pages for the NCCN guidelines, non-small cell lung cancer. I circled down there on the bottom, on the left, metastatic disease, which is what we've been talking about today, stage 4 non-small cell lung cancer. The next little arrow says establish a histologic subtype, which is what we've been talking about, ad nauseum today, about is it adenocarcinoma, et cetera. Talks about molecular testing, And then if you follow that arrow up, so assuming it's adenocarcinoma, which is the more common variant, then the next step is to make sure you've done all the testing, the EGFR, ALK, ROS, BRAF, MET, RET, and the PD-L1 testing, which we've talked about how important that is. And then each of those arrows after that points to, if they're positive for any of those first few mutations, there's a hyperlink to a whole nother page or set of pages that tells you how to treat EGFR mutation positive lung cancer. And it gives you the different drugs and the different kind of sequences or whatever. So you can kind of follow the cookbook, if you will, although it's still not easy to follow. And I can't, you guys can't see my pointer, I guess. So if you go down a couple below the MET and the RET, it talks about the PD-L1. And again, they differentiate that as well, whether it's negative less than 1 or positive more than 1. And then if it's more than 50, there's also another kind of bucket to go into as well in terms of how that plays out. So I'm going to go to the next slide. Did y'all follow that flow with me through that slide? Okay, I see some heads nodding. Okay. So then the next slide, so I clicked on adenocarcinoma. I think, let's see, I clicked on, what did I click on? I clicked on the one that basically said no mutations. So here we are, again, NCCN guidelines, non-small cell lung cancer. I've circled metastatic disease, initial systemic therapy. So how do I treat somebody who's got stage 4 adenocarcinoma? So then towards the top in the middle, it says PS 0 to 1. That's the performance status. So that's assuming the patient, performance status of 0 means there's 0 symptom. The patient is fully functional, able to work and vacation and do everything normally with no impact on their activity. So a PS1 is someone who's in great shape. PS0. PS1 is a mild impact, but still functioning well. So assuming the patient's in good shape, all the left-hand column are all of our options. And then they have, I circled the first one, which is it's a 3-drug regimen. The pembrolizumab is one of the immune therapy drugs. And I'm not here to advertise any drugs over the others. And then 2 chemotherapy drugs, the carboplatin and the pemetrexed. You may recall that we mentioned pemetrexed back in 2000 and whatever year that was, 6 or 7 or 8 or something, where that was shown to be more effective for adenocarcinomas than squamous cell. So that's one regimen that we often use in that setting. Another one that I circled is another immunotherapy drug, atezolizumab with carboplatin and paclitaxel. And this is a 4-drug regimen that adds on bevacizumab, which you may also remember around the same time we learned about the pemetrexed versus gemcitabine for adeno versus squamous. We also learned that bevacizumab added the benefit for lung cancer and was approved. So this is a decision to make, do I think the patient can tolerate the bevacizumab or not? The paclitaxel is a different drug than the pemetrexed. So there's a few pros and cons of each regimen in terms of different side effect profiles. They've not been compared head to head to really know which one's better than the other, but they're both really, really good. So those are some common options we use using chemotherapy and immune therapy. And then the newest one, I saw an advertisement this weekend about it. It's a very nice ad with a sailboat and everything else, but it's using nivolumab and ipilimumab, which are also immune therapy drugs. And you can notice there that there's no chemotherapy. So that's 2 immune therapy drugs without chemotherapy. So it gets to be a very complicated decision tree and conversation about how we approach. We've narrowed all this down, and we still got 3 good options here. The first 2 have chemo and immune therapy together, one of which has this biological drug, bevacizumab. The third option has no chemo and has 2 immune therapy drugs. So, how we all look at that varies probably doctor to doctor and patient to patient, but have some options. And then just the next set of options there's a bunch of them. It's contraindications to the immune therapy. These PD-1 and PD-L1 inhibitors are immune therapy drugs. So these are basically all chemotherapy combinations, some of which have that bevacizumab drug added to them. And so you can see it gets pretty complicated. Most of that is based on side effect profile. So that is really how I approach my new lung cancer patients with stage 4 non-small cell lung cancer. Any questions about this or anything else about lung cancer?